Yeah.
Hello, thank you for joining. Thank you for joining us today for the surgical illustration presentations by the class of 2026. I'm Corey Sandone. I'm the director of the Department of Art is Applied to Medicine, and I'm the course director for surgical illustration and the prerequisite course operating room sketching. These are team taught courses, and I want to thank the faculty in our department who have supported the students' education on these projects. We have 6 students. They've each observed and sketched dozens of surgical operations, and each student will present 2 procedures today. First, they'll show a series of pencil sketches developed to describe the procedure, and then they'll show their final artwork, 1 or more figures in the series. And in a related assignment, they depicted one of the operations for a lay audience. So you'll also see some of these patient education images included in their presentations. But overall, the work you will see today is designed to teach the operative steps to an audience of surgeons, residents, and fellows. The students have put a tremendous amount of effort, talent, and thoughtful design into creating each series of illustrations. These presentations can address 3 of the most common questions we get about medical illustration. Number 1, can't you just take a photograph? Students rarely use a camera in the operating room. They observe, sketch, and listen, and then they come back to the studio. They work up their first draft of sketches. They consult with the surgeon, make corrections or adjustments, and then they do a second review before creating their final illustration. They also work with faculty in the department and get feedback about some of the didactic illustration concepts. So the resulting images provide clarity, and they depict concepts that cannot be captured in a photo or a video. Question 2, hasn't it already all been drawn? Of course, human anatomy has been depicted for centuries, but the innovative procedures being developed at Hopkins and the creative techniques our students use to portray them have great value in the dissemination of new knowledge. And question number 3, how long did it take to draw that? One thing we can't help but notice is the beauty of the final images. They are gorgeous, and you can see them on the panels in the back, and you'll see them in the presentations. But the images that you're going to see today, not just the final artwork, but the sketches developed to depict the procedure, are really what medical illustrators do. We understand the subject matter and create effective images to convey information to a specific audience. And most importantly, we are teaching and grading the students on the accuracy, clarity, and effectiveness of the images. After each procedure is presented, the student will take questions and comments from our audience and our online viewers, and we really heartily welcome your feedback. We'll start with our first presenter, Jamie Heffley.
Thank you, Corey, and thank you all for being here. The first procedure I will present is a syndactyly release and reconstruction. My thanks to Dr. Lifshay for his feedback and the opportunity to observe. Syndactyly is a congenital condition in which two or more fingers do not fully separate during development, leaving them fused. Surgical release is typically performed between 12 and 18 months of age to support normal growth and function. The patient observed was 5 years old and presented with bilateral complete complex syndactyly of the 4th and 5th digits or the ring and small finger. This means fusion extended to the fingertips involving a bony connection. The patient also had simple incomplete syndactyly between the 3rd and 4th digits. Due to the length disparity between the ring and small fingers, their separation is prioritized to prevent progressive angular deformity and soft tissue tension. Release of the middle and ring fingers will be planned for a future procedure. Figure 1A outlines the dorsal planned incisions, including division of the shared nail plate, creation of interdigital flaps, and a design of a rectangular web hood for web space reconstruction. In 1B, the Palmer view demonstrates the planned perinechial flaps, which are the V-shaped incisions at the fingertip that will form the skin fold bordering the divided nail plate. Also detailed are interdigitating flaps and a reverse T-shaped incision, which is placed more proximally than that of the native web space to account for postoperative web creep. Beginning distally, an incision is made to mobilize the perinechial skin flaps, followed by separation of the nail plate at the junction of the ring and small finger. In 2A, the skin flaps are elevated and retracted with care to preserve the epidermis, dermis, and sufficient subcutaneous fat to maintain flap viability. Interdigital flaps are raised distal to proximal on the dorsal side, followed by elevation of the palmar flaps. Again, here we appreciate the disparity in finger length. 3A indicates synostosis between the distal ring and small phalanx, which is transected using bone cutters, then smoothed with a bone rasp to restore proper alignment and contour. Using blunt dissection, the digits are separated with care taken to identify and preserve the proper digital arteries and nerves. 4B shows the completed separation. Next, the dorsal rectangular hood is advanced and inset to the reverse T-shaped incision for web space reconstruction. Interdigital flaps are advanced to the respective side of each digit, avoiding tension or vascular compromise. Perinechial flaps are inset and sutured, forming the perinechial folds, which border the nail plate. A full-thickness skin graft harvested from the patient's right lateral groin is divided and placed to resurface exposed aspects of the created web space. The completed reconstruction shows fully separated digits with restored web spaces. Areas of gaping are closed with simple interrupted sutures. Complete skin coverage is confirmed, and fingertip perfusion is assessed. For my final illustration, I rendered a few of the key reconstruction steps, beginning with an orientation of the planned incisions for flap recreation. I chose to render in grayscale to rely on contrast and shading for clear visualization of flap design and tissue planes, which I thought color might distract from. This concludes my first presentation, and I welcome any questions or comments regarding my illustration. Yes, Tim.
Thought you made a good choice in handling fingers in tone and using flat local color, not local color, but a flat color to emphasize the flat in place and how all of this geometry is going back together. Nicely done.
Thank you, Tim. Corey?
Was the skin cut in zigzag formation supposed to straighten?
As opposed to a straight?
Supposed to-
The zigzag is a pattern typically used by the surgeon to help with scarring and help with the covering of raw tissue that may be exposed during the procedure. And it helps distribute it more evenly. Yes.
I'm Mayor Powell from Department of Medicine. This is fantastic work. Approximately how long does it take to do this? I'm not familiar with this and it's kind of fascinating.
It takes quite a bit of time. I think in the process, I'm sure for those who are experienced have done this more times than I have a quicker process. But we start in the OR, we sketch there, and we bring those sketches from our direct observations back to the studio. We will work on them further, refine them, go back and forth with several iterations of feedback with the surgeon and our faculty advisors to ensure that they're accurate. This took us, I'd say, like about a month to prepare.
As a non-surgeon, I thought it was incredibly clear. Cedar, I know Dr. J and very privileged to work with that, so thank you.
Thank you. If there are no additional questions or comments, I would now, I'll now proceed to my second procedure. My second procedure is a cholecystectomy with intraoperative phalangiography by Dr. Florecki and Dr. Bouchard, followed by an endoscopic retrograde cholangiopancreatography, or ERCP, which was performed by Dr. Kashab. A cholecystectomy is the surgical removal of the gallbladder, typically performed to treat gallstones or gallbladder inflammation. It is often accompanied by an intraoperative cholangiogram, which helps confirm the location of the cystic duct and identify bile duct obstructions. Findings from the cholangiogram may indicate the need for additional interventions such as an ERCP. To begin, the cholecystectomy is performed laparoscopically. The abdomen is insufflated and the surgical ports are placed. The camera is inserted through the umbilicus and the patient is placed in reverse Trendelenburg with the left side slightly angled down. The gallbladder is grasped and retracted cephalad. Using electrocautery, the peritoneum of the medial and lateral aspects of the gallbladder are incised. Blunt dissection is used to isolate the cystic duct and artery. An intraoperative cholangiogram is performed to visualize biliary anatomy and bile flow. A clip is placed on the cystic duct distally. The duct is then partially transected. A cholangiogram catheter is inserted into this opening in the cystic duct. Depending on surgeon preference, a clip may be applied to secure the catheter. An occlusion balloon is inflated and water-soluble contrast is injected to visualize the biliary anatomy. Fluoroscopic imaging showed retrograde filling of the intrahepatic and common bile ducts with a distal filling defect and no contrast passage into the duodenum. These findings are consistent with distal biliary obstruction, and a post-operative ERCP was performed, which will be detailed later in this presentation. To continue with the cholecystectomy, 2 clips are applied to the cystic artery proximally and 1 distally. The artery is then transected between the clips. The same technique was applied to the cystic duct. Finally, the gallbladder is mobilized from the liver bed with electrocautery and removed with an endocat retrieval bag through the epigastric port. The gallbladder has been removed and an obstruction in the biliary duct was identified, however not addressed in this procedure. To clear the biliary duct obstruction, an ERCP was performed the following day. This is an overview of the procedure created for a lay audience. A side viewing endoscope is advanced through the mouth to the duodenum, where the major papilla is located. A guide wire is inserted through the major papilla into the common bile duct under fluoroscopic guidance to achieve selective cannulation, and contrast dye is injected to identify the obstruction. The cutting wire of the sphincteratome enlarges the bile duct opening into the duodenum. And an extraction balloon catheter is then advanced past the obstruction, inflated, trawled several times to retrieve stones or biliary sludge from the bile duct. Repeat contrast injection under fluoroscopy confirmed restoration of bile flow into the duodenum. For my final piece, I chose to create a colored illustration featuring the cholangiogram approach because I thought it would be interesting to visualize a part of the procedure which cannot be seen from the surgical view. In the right inset, you can see the cholangiogram catheter within the cystic duct and the inflated obstruction balloon. I also used arrows to indicate contrast flow through the cystic and bile ducts. This concludes my presentation, and I welcome any comments. Yes, David.
Just wanted, so this is so I think you captured procedure very nicely and throughout your sketches and pieces, well, just did a wonderful job of answering the second question on that. You were very judicious in what you render and what you sketches. I just want to say this as maybe more into the presentation and work. I love the kind of the exposure of each of the steps that we're taking through. I don't know if that's something you guys decide on this group. It's very effective. You did great thing to offer clients as they're using our images to present. It's just a great job. He's taking beautifully presented.
Thank you, David.
It's really nice to see the last team keep their process students with the teams pre-plans already, so it's sort of relatively well this back but I always find something. It was really fantastic. One thing I would consider is just the background content is brought to a very high level of polish. You might try to sing that back just a little bit from frequently. It's just so you and strongly on this fact and there that lost this.
Yeah, thank you for the suggestion, Lydia.
I'll just talk loudly. A wonderful color palette, good, very effective tissue reaction, and transparency that you achieve showing the catheter side. Overall, it's got a great sense of place and it's well done.
Thank you, Tim. If
we have a question from our YouTube audience or a comment from Grace Hertzberg, an alum. Great command of your arrows here. Be watchful of your contrast with white LLs, especially for your occlusion balloon, maybe less contrasty on stream.
Thank you, Grace. If there are no additional questions or comments, I would like to welcome my classmate and friend, Caitlin Simla, to present. Good afternoon, and thank you for the introduction, Jay. The first case I will be presenting today is a right reverse total shoulder arthroplasty. Thank you to Dr. McFarland for allowing me to observe this procedure. This case differs from a typical shoulder arthroplasty or shoulder joint replacement. The ball and socket joint is reversed, the glenoid fossa becomes the ball, and the humeral head becomes the socket. A reverse arthroplasty is performed when a patient has severe arthritis and a large irreparable rotator cuff tear. In Figure 1, we can see the diseased humeral head, and to begin this procedure, an incision is made along the deltopectoral groove. Throughout the duration of this surgery, a mobile surgical table is removed and returned to support the arm. Following the skin incision, fascia is dissected to expose several structures. The deltoid muscle, cephalic vein, pectoralis major muscle, and conjoint tendon are retracted. The anterior humeral circumflex vessels, or three sisters, are sutured and ligated. Finally, as seen in this figure, the biceps tendon sheath can be incised. After opening the sheath, the tendon is elevated, sutured, and transected proximally. A subscapularis peel is performed with electrocautery to remove the subscapularis muscle and joint capsule from their attachment on the lesser tubercle. The subscapularis muscle is sutured and peeled away with a Hohmann retractor. The surgical table is then removed to extend the shoulder joint, and with the muscle attachments freed and the joint capsule opened, the humeral head can be dislocated from the glenoid fossa on the scapula. The humeral head is measured and marked with electrocautery and a humeral resection guide at 30 degrees. The guide is removed and the humeral head is resected with a bone saw. The humerus is drilled, reamed, and fitted for a humeral implant, which is then hammered in with a broach. This process is repeated, increasing in diameter until the desired fit is achieved. The surgical table is returned to support the arm, and a glenoid access retractor depresses the humerus while elevating the scapula for easy access to the glenoid. The glenohumeral ligaments, biceps tendon remnant, and labrum are removed from the glenoid fossa. A pilot wire is drilled into the center of the glenoid, and using the pilot wire as a guide, a half-moon reamer can be slid on and off the glenoid surface for pulse reaming. The inferior half of the glenoid is reamed to expose subchondral bone. The pilot wire is then removed and replaced with a center screw and base plate, which is secured with 4 radiating screws. After installation of the glenoid base plate, the surgical table is removed and the shoulder is again extended. Both the humeral socket implant and glenoid sphere implant are test fitted for a range of motion. Once satisfied, the surgeon will remove the test implants and install the final implants, and the shoulder joint is stabilized into the reverse ball and socket. The remaining biceps tendon is cut and sutured to the subscapularis muscle. The deltoid and pectoralis major muscles are sutured, and the incision is closed with interrupted mattress sutures. For my final color illustration, I chose to illustrate step 7 because reaming the glenoid surface of the scapula is important for proper installation of the base plate and later the sphere implant. I now welcome any questions, comments, or feedback. Thank you.
This comment has to do with your process as much as it does the results. So you go through the process, people who are part of the teams see this beautiful work of the sketches and piece, but watching you work through the steps and really refine what you observe and checking anatomy and and watching you go through the steps of research and talking to the surgeon, it really paid off. Very interesting to see what the process, but we did all the steps that it takes to do it. So yeah, more about process and these work through essentially the process. I think I know it's frustrating at times. Again, it goes to one of Corey's comments about how you see these things in surgery, and often it's just massive tissue. It really takes talking with the surgeon, observing notes, checking many sources to get a
Thank you so much, David, and thank you for all your help throughout the process.
Hey Caitlin, I really liked how you showed action in all your sketches and in the final piece too. I love that arrow, and I really like the action lines when you went hammer. And I feel like I wouldn't even mind seeing those action lines, you know, they look cartoony, but I feel comfortable in final piece. So I just like how you put action for all of those sketches.
Thank you so much. Yeah, I can definitely add more emphasis to the hammering. It was a lot of fun to watch and also illustrate.
Is the instrumentation done 3D or you can draw it?
So the question was if my instruments were created in 3D or if they were drawn. The answer is for any of the sketches that you see previously, they were done just by looking and observing at a variety of resources. But for my final illustration, I decided to jump into Cinema 4D, which is a modeling software. And I modeled my half-moon reamer head and pilot wire, as well as the Hohmann retractors and the glenoid axis retractor. And I utilized some of the renders from that to both emphasize my light on form and my shadows, and also how they would interact with the tissue.
Just a quick question. Beautiful rendering of tissue reaction comes out. I'm sitting here looking at tractors and I know they're not that important. And I don't know, you know, in projection we do some resolution. I'm sorry, I'm just talking about that. I'm wondering whether it looked like a 10% darker tone right under the highlight around tractors will help frame and cause the viewer to move more inside. Just a thought.
Mm-hmm. The feedback was adding more contrast around the highlights on the retractors. I really struggled when painting kind of these flat sloping surfaces. And so I would love to explore increasing the contrast and kind of drawing the eye towards the center glenoid, if that helps. Thank you for your comment.
So have your arrow, I agree with you, I love the unit, love it. But on your reamer, is that a highlight around your arrowhead, the shaft of the arrow, or is it no?
The question is if there is a highlight or an outline or stroke around my arrow on the half moon reamer. I chose to have a light stroke applied to my arrow to help give it more contrast against the black surface of the half moon reamer.
Yeah, this is very, it's kind of interesting to see, because I feel like I can see a highlight on the backside of the arrowhead, which would contradict the angle that's just slightly compact. So very picky thing, but
Thank you for the feedback.
Hello. First of all, I want to say, as a new faculty member, I didn't get to see the whole process of surgical, so I was wondering, see you and Jamie's, all the amount of work that you put into breaking down each step, and how intimately you know the surgical procedure. I want to piggyback on Tim's comments about emphasizing some of the shadows and pushing the lights and darks a little bit. The surgical window has a lot going on, and what might help is maybe even getting some of your shadows and highlights to have a hard edge, especially where objects are a little closer together, and that will help kind of separate all the things from each other. Right now, the shadows and highlights are very soft, so it's hard to know what to focus on because there's so much going on in the surgical window. But other than that, I think very beautiful job.
Thank you, Mansan.
From our YouTube audience, Jennifer Fairman, faculty in the department, suggests that she might suggest that you decrease the transparency of your blue arrow below so that the hole in the instrument is not showing through.
The comment from our YouTube audience from Jennifer Fairman was whether I should decrease the blue of my arrow. Thank you for the feedback. I will attempt to
So I will just decrease the transparency,
decrease it.
decrease it like less transparent.
I will explore some more opaque arrows. Thank you for the comment. If there are no further questions, I will move on to my next case. Thank you for the feedback and the comments. The next procedure I will be presenting is a distal pancreatectomy with splenectomy. Thank you to Dr. Burkhart for allowing me to observe this procedure. A distal pancreatectomy is performed to remove cancerous tumors from the tail of the pancreas. The pancreas head remains in the body after surgery to maintain blood sugar and digestion and will continue to function normally. In some cases, the tumor also affects the splenic vessels feeding the spleen. Therefore, it is not uncommon that a splenectomy or removal of the spleen is also performed. To begin, 5 main ports, including a camera port, are placed in the abdomen. An additional incision is made below the xiphoid process for retraction of the stomach. After deflation of the stomach, the gastrocolic ligament is divided with special care to preserve the gastroepiploic vessels and epiploic arcade with the greater omentum. The stomach is elevated, and the pars flaccida is dissected open. After a sub-xiphoid stab incision is made, umbilical tape can be fed under the stomach and returned through the incision to retract the stomach. The stomach is now protected and elevated from the operative field, and the pancreas can be fully visualized. The pancreatic neck is then dissected off the superior mesenteric vein and artery with an electrocautery hook and is encircled with a Penrose drain. Next, the splenic artery is identified, skeletonized, and tagged. With the splenic artery identified and the Penrose drain holding a passageway open for a stapler, the neck of the pancreas can be safely divided. After further dissection, the inferior mesenteric vein is identified. In figure 9A, it is skeletonized from the surrounding fascia, and in 9B, it is clipped, and in 9C, it is divided with scissors. Using the tag as a guide, the splenic artery is stapled, and the same process is continued for the splenic vein, as it is skeletonized, tagged, and stapled. In figure 11A, the splenic flexure and greater omentum are mobilized from the spleen and the stomach. With all vessels divided, the distal pancreas and spleen can now be dissected and elevated from the retroperitoneum, as seen in 11B. To mobilize the spleen, the short gastric ligaments and vessels are divided with a vessel sealer, and the splenocolic and renosplenic ligaments are also divided. Finally, division of lateral attachments from the body wall completes the mobilization of the spleen. The distal pancreas, splenic artery and vein, and spleen can now be removed via an endocatch bag through an incision in the umbilicus. My full color illustration depicts the pancreas with major vessels in the upper left-hand corner. This illustration summarizes 4 key intraoperative surgical steps to isolate the distal pancreas and spleen prior to mobilization from the retroperitoneum. These steps include 1, dividing the neck of the pancreas, 2, the inferior mesenteric vein, and 3, the splenic artery. Finally, as illustrated in the hero image, number 4 depicts the division of the splenic vein with a stapler. I now welcome any questions, comments, and feedback. Thank you.
I love these. In this case in particular, I love the colors. I think the image on the right, it has a beautiful ethereal quality in the background. I might just suggest a few more wet highlights in the primary area of action, because it gets a little lost, and I think that is where you want to follow the eye. And I think we're so close, just a few minutes there, but really beautiful.
Thank you, Anne. The feedback was to add a couple more wet highlights in the area of focus in the main image.
It's so perfect as we're describing things to match up. First, which is second, you see, was obviously awesome. It's just so you can really the fat runner is really, really beautiful, right? Obviously, there's a constant past people who just want to help in areas that aren't really close. You basically just putting this little warm shadow so that it's just as straight to the point as she just. Those are good sections.
Thank you so much, Lydia.
Also having to do with the fat and the pancreas, I think along the way, your pancreas and fat renderings are similar. I think you have to toned it down. You've also accentuated the very subtle difference in glandular pattern tissue of the pancreas and the fat. And that shows here. It's subtle, but pancreas doesn't reflect fat. It's got that flattening lobular one. That's really, that's a nice thing.
Thank you, and thank you for your feedback throughout the process.
Beautiful, creepy quality action. For old eyes like mine, I think the text could be slightly larger size. But it's got a great atmosphere and perspective to the entire since we've done.
Thank you, Tim.
I would say higher contrast as well, Tim. I don't know, but you know, the white should be white. I love the subtlety of the transparency, but I think we're losing a factor more than we should. So I would just punch that up.
I think what we find in these images is that we're looking at them on screen, so much more color and depth of value and tone. When they get projected here, it gets a little washed out. So I guess I would say defend it, knowing that, you know, it's for print, probably all the things we're talking about, you've probably already done.
I still welcome the feedback, and I do want it to be accessible to an audience on a slideshow. So I will adjust and increase the contrast depending on its output. So thank you.
My eyes aren't quite as old as Tim.
Andrew Cameron from the Department of Surgery. I think this image is absolutely beautiful. Everybody's looking with great interest at the image on the right. It's ethereal quality, it's flat. That is laparoscopy. You know, that to me, I'm looking at a screen and that's what it looks like in the OR. It's not a good procedure. That's what it looks like on the screen. And it's really well depicted. And there is kind of a lot going on in there, but you've almost narrated the whole operation with this one sad image, which is so cool. And I can almost replay in my mind what happened. And then you got a really simple, almost cartoon up to the left to decode what's going on in the picture. So I think it's really, really well done. Explaining exactly what it looks like. It's just really, really well done. I think you're really caught in them and really tell us the full operation.
Thank you so much.
From our YouTube audience, Scott Rollins has a comment. He says, how about a slightly darker edge to the inset on the colored illustration, making a subtle outline?
Thank you for the feedback. I will explore different opportunities to draw the eye to that inset. If there are no further feedback or comments, I will now introduce our next presenter, my classmate and friend, Allison Abel. Thank you. Thank you, Caitlin. The first procedure I will be presenting today is a submandibular gland excision. Thanks to Dr. Isley for letting me observe the procedure and for all of his helpful feedback during the sketch phase. This is a patient education piece I created about a submandibular gland excision. The submandibular glands are salivary glands located under the mandible. These glands may need to be removed because of salivary stones, which are hardened mineral deposits that can form in the gland tissue or ducts. Salivary stones can be painful and lead to infection, so surgical removal may be recommended. After a skin incision is made 2 inches below the angle of the mandible, the platysma muscle is dissected. Care is taken to avoid incising the marginal mandibular branch of the facial nerve, which I have highlighted in yellow. And the next step, sorry. Next, the subplatysmal flaps are elevated and secured with stay sutures. The deep cervical fascia is divided, revealing the submandibular gland below. In figure 3, the facial vein is divided and ligated where it passes superficially over the posterior aspect of the submandibular gland with careful protection of the marginal mandibular nerve. Utilization of the Hayes-Martin maneuver, which I have shown on the right, protects the marginal mandibular nerve from damage. Tension on the facial vein prior to division results in both the retraction of the superior portion of the facial vein and the marginal mandibular nerve, safely removing them both from the operative field. The facial artery is then ligated and divided as it enters the submandibular gland posteriorly. Because the facial artery travels through the submandibular gland, inferior retraction of the gland allows for secondary division and ligation of the facial artery to further free the gland. In figure 6, again, inferior retraction allows for visualization of the submandibular duct, which is highlighted in pink, and the submandibular ganglion and lingual nerve, which are both highlighted in yellow. Careful dissection separates the duct from its association with the ganglion and ensures preservation of the lingual nerve. The duct is then divided and ligated. Continued dissection further isolates the submandibular ganglion. The ganglion is divided and ligated with care to again avoid entrapment of the lingual nerve. After the attachment to the submandibular ganglion is cut, the gland is removed. The wound is closed in layers using dissolvable sutures. For my final illustrations, I chose to illustrate the last 2 steps of the procedure for a journal layout, and here they are in that journal layout. The upper left illustration is the dissection and ligation of the submandibular duct, and the lower right is the dissection and ligation of the submandibular ganglion. This is a closer view of the illustration that shows the dissection and ligation of the duct, and in both images, the larger inset shows the dissection step, and the smaller circular inset illustrates the division of the structure. And this is a closer view of the dissection and division of the submandibular ganglion. I now welcome any comments or feedback about the illustrations.
Your remnant from itself and the lens tissue attraction to the instrument just is explicit. So it's a good piece of colors and the story. Very successful. Congratulations.
Thank you. If there are no more comments or questions, I will move on to the second procedure. My second procedure is a ligation and transposition of an aberrant right subclavian artery. Thank you to Dr. Ha and Dr. Black for letting me observe the procedure and for all of their helpful feedback. On the left, the anatomy of the normal aortic arch is shown, and typically there are 3 branches that exit the arch. The brachiocephalic trunk will branch into the right subclavian artery and the right common carotid. The second branch is the left common carotid, and the final branch is the left subclavian artery. An aberrant right subclavian artery, or ARSA, which I have shown in pink, is one of the most common congenital anomalies of the aortic arch. In this condition, the right subclavian artery exits directly off of the aortic arch, lateral to the left subclavian artery, traveling posterior to both the aorta and the esophagus. This condition can cause chest pain and difficulty swallowing, and these symptomatic ARSA cases require surgical intervention. Treatment of this condition involves 2 procedures. First, a robot-assisted thoracoscopic ligation of the ARSA from the aortic arch, and then an open transposition that anastomoses the ARSA to the right common carotid, which I will detail later. For the robot-assisted thoracoscopic ligation, the patient is in right lateral decubitus to access the left thorax. 3 robotic ports are placed, 1 in the 5th intercostal space, 2 in the 6th intercostal space. An assist port and the camera are also located in the 6th intercostal space. The left lung is deflated to allow for visualization of the aorta and its branches. After port and camera placement, the parietal pleura is opened posterior to the aorta, overlying the ARSA, which is again highlighted in pink. The pleura is dissected to provide additional exposure, and a lymphatic vessel is clipped and ligated where it travels over the aberrant artery. Blunt dissection and bipolar cautery further free the ARSA. The artery is elevated with a vessel loop, and an intercostal artery is clipped and ligated to provide additional clearance for vessel stapling. An 8mm vascular stapler is then used to ligate the ARSA flush to the aortic arch. And the distal end of the ARSA is then dissected to prepare for the mobilization and transposition, which removes the artery from the retroesophageal space. The transposition portion of the procedure, the patient is repositioned supine with the head turned to the left to access the right neck. In this transposition, the distal end of the ligated aberrant right subclavian is anastomosed to the right common carotid to restore blood flow to the right arm. A transverse incision is made above the head of the clavicle, and the subplatysmal flaps are raised and retracted. The sternal and clavicular heads of the sternocleidomastoid muscle are retracted to reveal the right common carotid and right external jugular vein as they travel inside the carotid sheath. In Figure 6, the superficial portion of the carotid sheath has been dissected, and the external jugular vein and vagus nerve are mobilized laterally. The floor of the carotid sheath is then dissected to reveal the aberrant right subclavian. In this image, the aorta is ghosted to show the proximal end of the ARSA still attached to the aortic arch, and the freed distal end where it lies posterior to the aorta. The distal end of the ARSA is then retracted from the mediastinum and brought into the supraclavicular exposure. The artery is cut for length. The approximate location of this cut is indicated by the dotted line on the artery, and then suction to remove any clots. An end-to-side anastomosis of the cut aberrant artery to the right common carotid is completed using 5-0 sutures. Blood flow is checked with ultrasound before wound closure and drain placement. And on the left, again, we have the preoperative appearance of the aberrant right subclavian where it exits directly off of the aortic arch. And then in the post-operative view, we see the anastomosis of the aberrant right subclavian to the right common carotid. For my final illustration, I created a summary of the procedure for a half-page journal layout. In the upper left, a pre- and post-op ARSA diagram introduces the viewer to the procedure. The piece is then divided and organized into thoracoscopic and open transposition portions. The thoracoscopic portion, I chose to illustrate the distal dissection of the aberrant right subclavian in the thorax. And in Figures 2 and 3, which show steps in the open transposition, I illustrated the exposure of the aberrant right subclavian artery in the operative field and the creation of the final anastomosis to the right common carotid. In Figure 2, the aorta and great vessels are ghosted to clearly connect the previous ligation steps to the transposition, allowing the viewer to visualize the free distal end of the aberrant right subclavian that will be anastomosed to the right common carotid. I welcome any comments or questions.
This is just a The one thing that catches my eye, and I know this came up, is the movement of the pattern harmony through the overflow. I like it a lot better here in soft, very kind of visceral. I'm wondering if you could still play with that a little bit. If you look at the inside field coming off of progressive areas in the kind of grounded, very level. I'm wondering if you can explore that a little bit more. So it's still really clear that that's a meaningful community state arching the aura, but maybe a little bit less. This is that it's heading the right direction. I'd love to see if you have this story. It's not only comment, it's just.
Thank you for the suggestion.
The very ambitious surgery illustration tackled a lot of problem solving and petition, pictorial presentation here. To David's comment, I'm wondering whether if we're looking through the aorta into the orifice of that particular vessel, there was a little bit of a highlight kind of cascading over the bottom, what would be the edge, kind of lead us into that little tunnel. That might be something you might explore.
Thank you.
Yeah, I really agree with Tim on that. Probably cover that lower right part a little bit more, but it looks like the center component of the aorta is lower capacity to see through the side edge. But I just want to say, I'm so excited to work on this piece because I love it. Just as I love blood vessels. This is the flow of the piece is just fantastic. The drawing you did there is it's very simple, but the color coding out there is just the best shape. It's just awesome. The little shadow that I think you have cast on this picture that just does, I might get rid of that. It looks a bit more like smear of blur. And I just think it's just like stand out against that start. Just a bit. So something says
On which part? The
two lines.
oh, okay.
Just
Yeah.
If there are no other questions or comments, I would now like to introduce our next presenter, Elise Butler. Thanks, Allie. Thank you, everybody, for coming. The first procedure I illustrated was a left pterional craniotomy with an anterior communicating artery aneurysm clipping. Thank you to Dr. Tamargo for his help with these illustrations and for having me in the OR. This is a patient education piece I made explaining aneurysms and aneurysm clipping for a lay audience. An aneurysm forms when blood flow presses against a weak area of a vessel wall, creating a bulge. A ruptured aneurysm causes uncontrolled bleeding and is an emergency. One treatment for aneurysms is to place a small metal clip at their base, blocking blood flow. Here's an overview of the relevant anatomy. This is the frontal lobe. There's the temporal lobe, and indicated between them is a fissure called the Sylvian fissure. The anterior communicating artery aneurysm is deep in the skull, sitting on top of the optic nerve near the skull base. Exposing it requires multiple steps, which I'll take you through. The aneurysm will be accessed through the Sylvian fissure. A pterional craniotomy was performed to access the aneurysm. The patient was placed in a Mayfield clamp with the head angled 45 degrees to the right, and an incision was made as shown. The scalp was reflected anteriorly, and the temporalis muscle was cut with electrocautery as indicated, leaving a cuff of muscle behind. The temporalis muscle was reflected anteriorly, and 4 burr holes were created as indicated. A 5th hole was drilled lateral to the temporal ridge. A saw was used to cut between these holes for the craniotomy.
A drill and rongeur were used to eat the sphenoid bone away from the sylvian fissure. The dura mater was opened in a semicircle and reflected anteriorly. Arachnoid mater was dissected from the anterior sylvian fissure. Now the view will switch to a microscope as the neurosurgery begins. This camera indicates the angle and position of the microscope view. Imagine looking through the sylvian fissure into the center of the skull base. To orient you, the frontal lobe is at the top right, the temporal lobe is at the bottom left. The frontal lobe was retracted to reveal cranial nerve 1, the olfactory nerve, as dissection continued. The sylvian fissure was dissected to the optic nerve and internal carotid artery. Gyrus rectus is visible beside the olfactory nerve. Gyrus rectus was cauterized to reveal the aneurysm. Temporary clips were applied to the A1 segments of the anterior cerebral arteries to reduce blood flow to the aneurysm. A permanent clip was applied to the neck of the aneurysm. The temporary clips were removed, restoring normal blood flow. The aneurysm deflates. The dura was closed, and the cranium was replaced and secured with interlink plates. Mesh is placed over the pterional region. The temporalis muscle is sutured to the muscle cuff and the mesh, shifting the bulk of the muscle forward to combat the cosmetic effects of muscle atrophy after the craniotomy. The surgical site was closed in 2 layers with a drain placed. I chose to fully illustrate the clipping of the aneurysm. I provide an overview of the craniotomy and a view of the temporary and permanent clips being placed. Here's a closer view of the top of the page and a closer view of the bottom of the page. I now welcome any questions or comments from the audience. The question is, oops, sorry, that was quite loud. The question is, what is the point of the temporary clips? So those temporary clips are placed because, can you see my mouse? Is my mouse visible? It is. Okay. So blood is flowing up through the internal carotid artery, up into the anterior cerebral artery right here. And blood is flowing up into this aneurysm. So these temporary clips are being placed at the base of each of these A1 segments of the anterior cerebral artery to prevent the blood flowing up into the aneurysm, and that softens it for easier clipping.
As well, and this was down to just a really basic teaching moments to create some transparency.
Thank you so much. Thank you for all your help. It was great working with you.
Yeah, Louise, this is kind of a follow-up to Alex's question, but once the clip is placed, how does the aneurysm deflate?
The question is, how does the aneurysm deflate after the clip is placed? Lydia can correct me if I'm wrong, but I believe that there are small little arteries kind of attached to that aneurysm that can still like drain blood away from it after the clip is placed. So no blood is flowing into it, but blood is still slowly flowing out of it. Is that correct? Yeah, yeah.
That was a wonderful breakdown procedure, and I loved the scope angle to orient the viewer of where we are. I mostly have compliments. The aneurysm has a beautiful thin quality to it when we rendered it, and I love that treatment of the aneurysm. That's all I have to say. Joel.
Thank you, Mansan. All right, I'm going to move on to my next procedure. The second procedure I chose to illustrate was the reconstruction phase of the Whipple procedure. Thank you to Dr. He for letting me observe so many cases and for his help in developing these sketches. The Whipple procedure is indicated for some patients with cancer in the head of the pancreas. Here's an overview of the anatomy in the area. The head of the pancreas is nestled against the duodenum so that pancreatic fluids mix with bile and enter the GI tract at the duodenum. The pancreas is close to many important structures and shares vasculature with the duodenum. Removing just the pancreatic head would jeopardize blood flow to the duodenum. Therefore, surgeons perform a Whipple procedure, also known as a pancreaticoduodenectomy. The pancreatic head, duodenum, bile duct, and gallbladder are removed. On the left is an overview of the cuts made and the structures removed, and on the right is the removal of the Whipple specimen. The part of the procedure I illustrated begins here. The highlighted end of the jejunum will be pulled up and anastomosed with the pancreas, bile duct, and stomach to reconstruct the digestive tract. Move that off of the screen. This procedure was performed robotically. The ports were placed as shown, and the camera view is indicated. An assisting surgeon was standing between the patient's legs and had access through the center port. First, the jejunum is pulled up through the ligament of Treitz defect. It passes under the superior mesenteric vessels as it comes through the peritoneum. A pancreaticojejunostomy is performed, creating an end-to-side anastomosis between the pancreatic duct and the jejunum. V-lock suture is used to approximate the pancreas and jejunum, and proline suture is placed through the posterior wall of the pancreatic duct. A bipolar cautery hook and a needle are used to create a jejunotomy and open the mucosa. I'm showing the mucosa elevated as the surgeon creates the jejunotomy. A pediatric feeding tube is placed as a stent to maintain patency of the pancreatic duct. The proline sutures are used to approximate the duct and mucosa posteriorly. A double layer of proline sutures is used to complete the duct to mucosa anastomosis. The V-lock suture is run back across the pancreas to complete the pancreaticojejunostomy. About 4 centimeters distal to the pancreaticojejunostomy, a hepaticojejunostomy is performed, creating an end-to-side anastomosis between the common hepatic duct, shown in green, and the jejunum. A jejunotomy is created using a bipolar cautery hook and needle, as before. The common hepatic duct and jejunotomy are approximated posteriorly with a single layer of sutures. A pediatric feeding tube is placed to act as a stent. A second row of sutures is used to complete the hepaticojejunostomy anteriorly. The gastroduodenal artery was ligated during the resection, and it is wrapped to separate it from the anastomosis. This is done using ligament teres. This is the remnant of the fetal umbilical vein, which runs from the liver to the umbilicus. At the beginning of the surgery, it was taken down and preserved as a viable tissue flap for this step. The flap is passed between the stump of the artery and the anastomosis, wrapped around the artery and sutured to itself, and tucked behind the jejunum to secure it. The final anastomosis is a gastrojejunostomy, which is performed about 40 centimeters distal to the hepaticojejunostomy. This is a side-to-side anastomosis between the stomach and jejunum. The jejunum is pulled anterior to the transverse colon. A jejunotomy and gastrotomy are created, and the gastric mucosa is secured to the serosa with a suture. An endo-GI stapler is used to create a side-to-side anastomosis. This instrument cuts straight down the middle and staples on either side, creating a common channel between the stomach and jejunum. When the stapler is removed, the lumens of the stomach and jejunum are connected. The defect left by the stapler is closed with a double layer of V-lock sutures. Here's the detail of the suture pattern, and here are the sutures completed. Here's the finished reconstruction with the pancreaticojejunostomy, hepaticojejunostomy, and gastrojejunostomy. Here's an overview of the procedure with the normal anatomy on the left, as seen before, the anatomy after resection in the middle, and the anatomy reconstructed on the right. I chose to fully illustrate some of the steps of the pancreatic jejunostomy. The overview of the finished step is in the upper left-hand corner. The approximation of the pancreas and jejunum is in the center, and the jejunotomy creation and stent placement are shown to the right. I now welcome any questions or comments.
I was gonna make this comment at your surgical drawings. Some of your images that are complete, especially the final large circle picture, was very beautiful, incredibly accurate, and would be appropriate, for a surgeon like that, surgical labs. And so you've got an amazing skill set there. But your sketches are incredibly effective in communicating information. And they're very clear. And they almost detoxify the subject. If you're mentioning patient information, one of your early sketches for your neurosurgical procedure was something the patient could look at and say, okay, this is what's gonna happen. I think that looks okay. And the way you illustrate, a wimple, it's just really crystal clear what's going on in the operation. And again, you use sort of cursive text and you use, I don't know, it's almost casual when you just sketch it out. It's very, very effective in communicating information. It's actually what it's really awesome.
Thank you, I appreciate it.
That's exactly what. Because I do think this piece is stunning. Your sketches from a didactic perspective, I think are so applicable. I think they can be instructional to residents or professors. So I do think patients would understand what was said about the use of your handwriting. Just made it then delightful, and I think they're incredibly impactful. It'd be so interesting to take these two styles of the same procedure and do a little user testing on which style most effectively conveys the information needed to different audiences. So you have evaluation paper.
Yeah, all my free time. Thank you so much, Anne.
Steps was the orientation and the team. I guess that would be a sense of
Thank you, Alex.
I'll agree with a lot of what has been said. Beautiful final image, tissue reaction. I think what's interesting about your sketches, and people have intimated or talked about this, is that in each one you kind of give us a hint of where we are and where we're going. Then the next one, there's a little bit of that information behind that connects it to the next step and progresses throughout the entire storytelling. It's really a fine sense of visual communication and leading us along in a understandable path.
Thanks, Tim.
For one more comment, because I haven't been interested to see very well. The other thing to do about sketches is that they're language agnostic. So if you have someone, a patient or a family member, or anyone who, English is not their first language, which is what we have here, it conveys the action, direction, motion, step in a way that is universal to anyone who learns. Which I think is a big power of these sketches.
Thank you. Thank you so much, everyone, for your comments. It is now my pleasure to turn the stage over to my classmate, Melody Zhang.
Thank you so much, Elise. The first procedure I'd like to present is a facial artery musculomucosal or FAM flap procedure.
The tongue resection portion of the procedure was performed by Dr. Maddie, and the fan flap procedure was performed by Dr. Desai. A fan flap uses tissue from the inner cheek to reconstruct areas of the oral cavity. In this case, it was used to repair a defect created after removing a tumor on the patient's tongue. The facial artery is used to supply blood to the flap. To the right is a post-operative view of the procedure. The procedure begins with resection of the tumor using a microdissection needle. An incision is made superior to inferior on the inner cheek to create the flap. The superior labial artery and inferior labial artery are clipped and divided as the mucosa is cauterized. Dissection continues with care taken to avoid the parotid duct opening. The superior portion of the facial artery is tied and the flap is released, containing a portion of the buccinator muscle, the buccal fat pad, and submucosa from the inner cheek. The flap is matched up and then sutured to the tongue. The cheek mucosa is closed, with a pedicle left intact to supply blood to the flap. For my final illustration, I chose to show the moment the flap is released and positioned over the tongue, presented in a journal-style layout, with the final illustration formatted for print. I now welcome any questions, comments, or feedback from the audience.
I really like the steps that you went through. I'm not coming from a medical background, so I feel like in terms of as a patient, it would be very interesting to see those steps because I heard you did a really good job of making it clear what would happen on each step. I like how it was highlighted what part you're supposed to be paying attention to. This image is just beautiful. I feel like you did a really good job.
Thank you so much.
So Melody, thanks, I'm the lion. So Melody, it's really nice to see the whole process from the operating room to the presentation. It actually, what seems like a really simple flap, there's not many descriptions, both in graphic form or technique form for anybody to actually learn how to do this. So I think this is a really helpful demonstration in addition to the very little literature we actually have on this. And then the other thing is every day I hear patients say I was not prepared for this, no matter how many words I use to tell them I'm going to take their thigh and put on the face, or what that's supposed to be, you know, their cheek and their tongue. And so I think this type of work is so critical and there's a huge need for it. So I'm very interested in how that leads you. Beautiful job with the process.
Yeah, it was great working with you, Dr. Maddie.
I have a question for you, Dr. Maddie. What made you decide to use a flap, and when's the patient small enough that you can just reconstruct it?
For the tongue itself in this case, it really comes down to location and size. So that this was a perfect case for a small, less than a third of the tongue, and on the side. So things that don't involve the floor, the mouth, the bone around it, or the further back of the tongue, posterior tongue. So these are very selective pieces, but when they're done, they can really save morbidity from much larger procedures like a pre-flap, or not having enough tissue, which can really affect articulation. So, thank you.
So you can show us the page layout again?
Yeah.
Yeah, I agree with all the positive comments. My only comment is make it bigger. Have a beautiful piece here and the lateral, the horizontal dimension of the moving factor columns. I would say make it sing. You might not always have control of that, but in this case you do. So I would push it as laterally as far as you can.
Okay, will do.
There.
If there just like this. If there are no more comments or feedback, thank you all for your feedback. I will now move on to the second procedure I illustrated. I observed a donor nephrectomy using the Da Vinci surgical system. Special thanks to Dr. Wesson for letting me observe the case. In a donor nephrectomy, a healthy kidney is removed from a donor and transplanted into a recipient whose kidneys are no longer functioning adequately. In the case I observed, the living donor was healthy and chose to donate to a stranger. The left kidney is a preferred kidney for transplant because of its longer renal vein, providing more length during implantation. The kidney is placed in the lower abdomen, which offers easier access to the necessary blood vessels and the bladder, making the transplant operation less invasive. After retrieval, the renal vessels are connected to the recipient's iliac vessels, and the ureter is attached to the bladder. During the procedure, the patient is in right lateral decubitus position, and the robotic camera provides two views. A superior view that captures the kidney and renal vessels, and an inferior view that shows the lower ureter and gonadal vessels. These two camera views will be in the top right corner of my presentation to help with orientation. The nephrectomy begins with mobilizing the colon. Monopolar scissors are used to cauterize the white line of Tolt, releasing the colon and exposing the retroperitoneum. Once the colon is released, the fat inferior to the kidney is dissected to identify the ureter. Moving inferiorly, the gonadal vessels are clipped and divided, while the ureter is preserved and loosely tied. Returning superiorly, the renal lumbar vein is located and cut. Gerota's fascia is released, exposing the left kidney. The adrenal vein is then clipped and cut. The ureter is clipped on the stay side, then divided, leaving the go side open and ready for transplantation. The left kidney is carefully lifted and flipped over the IVC and aorta to allow optimal access to the left renal vessels. The renal artery is stapled first, followed by the renal vein, releasing the kidney. After extraction, the kidney is flushed with saline to prepare for transplant. For my final illustration, I chose to depict the kidney flipped over the IVC and aorta, along with the critical steps of stapling the renal artery and then the renal vein prior to extraction. I now welcome any comments or questions.
Hi, my name is Russell Weston. I'm a surgeon, and I just want to say that it was absolutely delightful to work with. And, you know, these images in my mind, I'm not up to see it all, but these are fantastic. And I think what was really striking to me about this was that it shows the process, the whole procedure from start to finish. In a way that is very, it conveys all the moves to a surgeon. And it's to such an extent that I think that this would be very useful to help surgeons learn how to do this. You know, when you do a donor nephrectomy and someone's giving their kidney to someone else, you want to do it perfectly. And every move that should be must.
It was a pleasure working with you too, Dr. Wesson.
I just want us to go and do the lessons. This looks amazing. I just want to know, she's doing lots of the background, just is fantastic. You've, this is just such a great example of putting fat down in the equal way where it's a diffusion piece, but it doesn't distract from the overall formation. It's subdued, and it really just adds to the environment instead of taking out like so many touching. And everything's just really vibrant.
I wanted to especially thank you, Lydia, for helping me with this piece.
Is there a reason why the vein with the left kidney is longer than the right one?
If we go back to so actually that's just human anatomy. The IVC is located on the right side. So the left renal vein has to reach further to get to the kidney.
Let's say your applying liver test, all the necessary form and treaty quality to bring us right into the area of action and fading of the instruments and again, color situated, highlights situated in the area of action. It's a very effective piece.
Thanks, Tim. If there are no more comments, I will now give the floor to our final speaker, Ethan Gernert.
Good afternoon, everyone. I'm Ethan, and the first procedure I will be presenting is a left thyroid lobectomy. Special thanks to Dr. Matter for letting me observe and her constant feedback throughout this process. Figure 1, a thyroid lobectomy is performed to remove one half of the thyroid gland and preserve the contralateral lobe. The unaffected lobe of the thyroid is preserved to maintain hormone function of the gland. Shown in figure 1 is the relevant anatomy to this procedure, with specific attention towards the vasculature of the thyroid and the nerves. The superior laryngeal nerve runs close to the superior thyroid vessels. During ligation of these vessels, it can be easily injured. The vagus nerve controls various functions throughout the body, and damage could be devastating for the patient if not mapped out using nerve stimulation. And finally, the recurrent laryngeal nerve runs directly behind the thyroid, and damage can occur later in the procedure when the thyroid is being separated from the isthmus. Throughout the procedure, there is special care to identify and map out these three nerves to ensure there is no damage. Incision begins at 2 centimeters above the sternal notch using blunt dissection and electric cautery. The platysma and median raphe of the strap muscles are separated. In figure 2, the sternohyoid and sternothyroid muscular adhesions are grasped and dissected from the thyroid gland. These muscles sit directly above the thyroid and partially cover it. They are tightly adhered and they block the superior pole of the thyroid, the recurrent laryngeal nerve, and the vascular pedicles of the thyroid. These muscles are then retracted laterally to expose the left lobe of the thyroid to avoid traction injury to the recurrent laryngeal nerve during thyroid mobilization. In figure 3, the superior thyroid vessels and middle thyroid vein are identified with careful blunt dissection to expose the superior pole of the left thyroid lobe. These vessels are large, variable, and are closely associated with important nerves. They are ligated and divided. And isolating and ligating the superior vascular pedicle of the thyroid also protects the superior laryngeal nerve by acting as an important landmark. When these vessels are ligated, the superior pole is free and can be rotated and mobilized. Figure 4 shows the inferior thyroid vein ligated and divided, and the inferior thyroid artery ligated and divided. This is a conceptual image of the inferior vascular pedicle of the left lobe of the thyroid. The vessels sit in a deep, narrow, crowded space where bleeding is difficult to control and visibility is limited. These vessels also run directly next to the recurrent laryngeal nerve, and effective ligature of these vessels helps to identify this nerve. In figure 5, the thyroid is rotated medially. A nerve stimulator is used to identify the superior laryngeal nerve during the dissection of remaining adhesions. The superior laryngeal nerve runs close to the superior pole of the thyroid, and the nerve stimulator is used to map the nerve's paths to ensure nerve integrity during the dissection. Careful, sharp, and blunt dissection around the fibrous capsule of the thyroid is continued, with the nerve stimulator being utilized during each dissection. In figure 6, the thyroid is mobilized medially where Barry's ligament and adhesions are removed from the thyroid isthmus using electric cautery. Barry's ligament firmly attaches the thyroid to the trachea. This is the most dangerous step of the surgery due to its proximity to the recurrent laryngeal nerve. In figure 7, the gland is divided at the isthmus over the trachea. The isthmus is the bridge of tissue connecting the contralateral lobe of the thyroid to the one being removed. Division at the isthmus ensures there is no traction damage to the contralateral lobe. The left lobe of the thyroid is then removed and the wound is closed using simple continuous sutures to close the platysma and strap muscles, and subcuticular sutures are placed beneath the skin to reduce scarring. This procedure was illustrated for a journal format, and this is an example of how the sketches would be organized for the journal. The step I chose to illustrate was step 6, the removal of the adhesions from the isthmus of the thyroid, because it is a crucial and dangerous step to properly isolate the target lobe of the thyroid while preserving the contralateral lobe. I welcome any questions and comments. Thank you.
It's nice to see these elements coming down after keep them. It's really wonderful. Very clear. Very few two very small suggestions. I would put a darker outline around the property there. It's not standing out among the other tissue types. And the fade off from the external skin color, it's a little bit too abrupt. Just going, 100 to 0, just a very short distance. I would make that a much more gradual fade out to the vertex. It's kind of an example of how the space can take on a life of their own. It also it's like a secondary shape around the incision rather than just a fade out.
Thank you for the feedback.
I think overall your tissue reaction and manipulation is well done. I just have a little question about our area of incision there. It seems that the thyroid itself is squeezed so finely and so hard that it's thinning tissue out a fair amount. Was that purposeful or?
So the question was why the tissue feels so thin towards the incision line. It's because the isthmus is in the very center. It's very small for the thyroid, but there's a lot of very loose connective tissue around the isthmus. So it was to help illustrate them taking off some of the more finer adhesions as they move towards it. Is that what you mean? Oh.
That's more salt to the thyroid tissue. It just seems like it's very flat along that entire.
Yes, I would say there is more bulk, but maybe I overdid it trying to showcase the smaller adhesions compared to the rest of the gland.
But I think you've captured realistically the ligament and the modulation of that lobe. I think it's well done.
Thank you.
This is really done with the machines. Seeing these projected after seeing the stages of development. Nice change, beautifully sensitively rendered. My one comment would be about the vagus nerve. They're in the correct place, but the fact that we follow so perfectly the vasculature, they almost look like place. I'd love to see just introduce a little bit of treatment, a little bit more maintenance, so maybe one slightly behind the edge of moving vessel or artery. I think he'll draw more attention. He'll still be accurate, but he'll draw a little bit more attention to the nerves, which is but back to that, it's really nice sensitivity.
Thank you, David. If there's no more comments and feedback, I will move on to my next case. For my second case, I observe a robot-assisted total laparoscopic salpingo-oophorectomy. Special thanks to Dr. Stone for all her input and feedback throughout this process. This is a patient education piece that I created to describe the procedure. It explains that a hysterectomy removes the uterus and a salpingo-oophorectomy removes the fallopian tubes and ovaries. This procedure is performed for a variety of reasons, such as excessive menstrual bleeding, severe pain due to endometriosis, and cancer. In this specific case, the surgery was performed due to severe endometriosis. In figure 1, the patient is placed in steep Trendelenburg position with a 5mm trocar placed at Palmer's point to insufflate the abdomen. An 8mm robotic camera is placed at the umbilicus and 3 8mm trocar placements for the Da Vinci instruments on the sides of the patient. In figure 2, a uterine manipulator is inserted through the vaginal canal into the uterus to allow manipulation during surgery. A Foley catheter is placed in the urethra to deflate the bladder. In figure 3, the uterus is mobilized to the contralateral side of the body. A window is created in the posterior leaf of the broad ligament using blunt dissection to identify the ureter. Once the ureter is identified, blunt dissection is continued following the path of the ureter to the body wall to open the avascular space in the peritoneum to isolate the ovarian vessels and the IP ligament. Identifying the ureter before the ligation of vasculature of the uterus and the ovaries is a critical step of the procedure to ensure there is no damage to the ureter, but also use the ureter as an important landmark. This is then repeated on the contralateral side. Once the ureter has been identified and dissected, the ovarian vessels and the IP ligament are ligated together as seen in figure 4. These vessels run very closely to the ureter and is used to help identify these important landmarks to ensure safety of the patient. This is once again repeated on the contralateral side. In figure 5, the round ligament is divided and dissection of the broad ligament is continued towards the bladder following the course of the ureter. The round ligament keeps the uterus anteverted, and the dissection of the round ligament allows the uterus to be mobilized and rotated more easily by freeing its lateral attachment to the pelvic sidewall. This is also repeated on the other side. After the uterus has been separated from the peritoneum of the pelvic sidewall, the vesico-uterine peritoneum is then dissected as seen in figure 6. The vesico-uterine peritoneum opens an avascular plane that acts as a landmark for cervix removal later in the procedure. This step identifies the true bladder edge and reduces the risk of accidental entry into the bladder. In figure 7, the uterine vessels are ligated close to the uterus. The ureter is just beneath the uterine vessels and special care is taken to ligate the vessels as close to the uterus as possible. Once all of the vasculature of the uterus and ovaries has been ligated, the uterosacral ligaments are dissected from the base of the uterus as seen in figure 8. These ligaments specifically anchor the cervix and uterus to the pelvis, and dividing them is critical to fully free the uterus and cervix. This opens the lower pelvic space for free and fully expose where the cervix meets the vagina. This step also reduces the risk of accidental rectal injury by showing the boundary of the rectum. In figure 9, the uterus is incised at the cervicovaginal junction around the circumference of the colpotomy ring. The colpotomy ring is a part of the uterine manipulator that pushes against the vagina and marks where the cervix and vagina meet. This ring centralizes the uterus, so a controlled midline incision around the colpotomy ring can be performed. Incision around the circumference also confirms that there is a complete separation of the uterus, cervix, and any ligaments. Once the uterus has been fully freed, it is then removed through the vaginal canal, and the vaginal cuff is closed with simple continuous V-lock sutures. For my final illustration, I chose to illustrate figures 3, 4, and 5 of the procedure because identifying the ureter not only ensures that there is no damage to the ureter, but it is an important landmark throughout the entire procedure and is critical to ensure the safety of the patient and surgical efficiency. I now welcome any comments and questions.
There's a lot of beautiful drama in this image. I think you've got a successful color palette, tissue reaction, and you're leading us throughout the entire story with concentrating on areas of action. I think it's really well done.
Thank you.
I like the contrast in your images
too, in terms of, leading your eye exactly to what you're supposed to be looking at. I feel like you did a really good job with the shading and contrast.
Thank you.
Really love repeat, just one small comment. I think that the white text that's identifying some of the anatomical markers like we heard and brought like they get a little lost, so you might the treatment and color because they're beautifully rendered, and I think that they get a little lost maybe in projections and also the white contrast against some of the light tissue. Really nice job. I do want to comment for everyone. I'm always delighted when I see your signatures on your pieces. So if you didn't have a signature on your title piece, please put it on because you deserve the credit for the beautiful work.
Thank you, Anne, and thank you for the feedback.
I just want to comment on how I love the color palette in this for this final piece. And also the way you treated the ovarian vessels, and really you can see that it's kind of being in there's depth to them, and the way that you kind of fade it out and bringing a little bit more in focus as close to the surface is really lovely. And this is a general comment for everybody, kind of echoing what's been said already. Everyone's sketches are so well done and clear. And I just appreciate the extra effort you put into that first presentation where you had the nerves animated. And I thought that was great use of very simple animation as part of your storytelling procedure. So, job well done.
Thank you. It took forever to figure out on PowerPoint, but
Memorable and very effective. So I appreciate the effort you put into doing that.
I'd like to make a comment for all of the students today in your presentation, visuals, storytelling. I think you all need to be invited to grand rounds.
There's a recommendation from our YouTube audience, Grace Hertzberg, alumna. She recommends using a contrast checker to help ensure text legibility.
thank you, Grace.
Thanks.
Yep. Thank you, everyone.
So I want to thank everyone who helped the students achieve the success in this course, our faculty, the surgeons, residents, and fellows who welcomed the students to observe the cases, reviewed their sketches, and further explained the procedures, the OR staff, and I especially want to call out Kelly Burnett, who provided the very important and useful orientation to the operating room. Thank you, Kelly. Our students did that at the very beginning. This opportunity and our colleagues' willing participation in the course makes surgical illustration one of the strongest courses in our graduate program in medical illustration. And I want to thank all the comments today were great. I want to thank everybody for participating, including our online audience. I'd also like to thank Daisha for helping us with the projections and Ebony for helping with the students and the reception, setting up the artwork. And students, finally, congratulations on completing this really important milestone in your graduate education. Surgical illustration is complete. Enjoy your break next week. Onward with your thesis research. So congratulations, everyone did a great job. Please join us for a little reception on the right-hand side of the auditorium.